everyone. Happy Wednesday. For those of you joining from here in Central Time, good morning. For those of you joining from other places, good afternoon, maybe good night for some of you. My name is Hiva Kolodrubetz. I'm a family nurse practitioner, and I'm the Director of Advanced Practice here at Archer Review. And today's free webinar is geared towards those nurse practitioner students. That doesn't mean that if you are a nursing student or LPN or anywhere else in your nursing journey, this webinar could not be helpful to you, but I do want to set the tone and make sure you guys know that this is something that we're going to be talking about for advanced practice, for nurse practitioner training. So don't panic if you're studying for NCLEX. Maybe still a fun thing for you to listen to today, because we're going to be talking about something very common that we see all the time in our clinic settings and our hospital settings, and that's hypertension. So good afternoon, the midwifer traveler. Good afternoon. Some people are saying good afternoon. Emukur. So we're streaming from a lot of different places. So Instagram, you're probably watching us also on Facebook and YouTube, and also our LinkedIn. So lots of, I'm sorry, not LinkedIn, but our Zoom account. Didn't do LinkedIn today. Spared all of us. That's too many platforms to stream on as is. So welcome. I love to hear from you guys. So keep that chat box open. My goal for today is to really have this be an engaging 30-minute webinar. I know 30 minutes is fast, but I really want to focus in on hypertension. So get that chat box open and answer the questions I'm going to ask you. Ask me any questions you have. Volume issues on Zoom. Let me see if I can fix that, Anna. Thank you. Sometimes this happens on my computer when I am streaming on so many different platforms. So let me try this one. Is that better for audio? Natalie says now it's working. That's great. I did switch it, so hopefully that's a little bit better. Awesome. Thank you guys. I really appreciate that. And you guys are doing an awesome job engaging already. So let me make sure I have all my chats open and we can get started. So before we dive into product and all of that, I do want to let you guys know that we do have a one-day live review coming up next week. We're going to talk really in depth about hypertension. The point of our one-day live reviews is to really go over everything, high yield, high impact, so that you can then inform your studying if you're getting ready to sit for your boards exam, if you're getting ready to start your clinical rotation, whatever you're using that one-day live review to prepare for, it's really going to be the full breadth of what we're going to be responsible for in primary care as nurse practitioners entry level coming into clinical practice. So it's really intended to go over all the juicy, meaty things and say, hey, this is what you need to know. If you don't know it, write it down. This is what you're going to go back and study. And you do get a workbook with that, and you get all of the PDFs of our slides. So it really is a nice way to follow and be like, okay, I have to go back and review this. Okay, I have to go back and review that. With that board prep, you also get 30 days access to the recording. So if it's something that I said, or Dr. Boosie, my colleague who does the one-day live with me, if it's something that either of us said and you're like, hey, I want to go back and listen to that again, you get the recording. So if you scan that QR code, you get to go to the one-day live. Everything else we'll kind of talk about as we get later into today's webinar. But just know that we have a question bank, we have a video library. We're coming up with some free exit exams because we're beta testing them. So keep an eye on that. I'm super excited. We wrote that in December, and I can't wait. Actually, it took November and December to write those exams, and I can't wait for it to hit our website so you guys can trial it. But those are the main juicy products that we have for you guys available today, and we're working on a lot more. So lots to come. So let's talk about hypertension. This is one of my favorite subjects to talk about because I see hypertension a lot in clinic, and I see my colleagues ignoring hypertension a lot. Patients would love to ignore hypertension, right? It's silent. They're not really going to understand the effects of hypertension because it's happening in the heart, kidneys, lungs, all those end organs. But we as clinicians need to understand and prevent those conditions from happening by treating the underlying silent hypertension. So this is something that's really I'm passionate about talking about it. Anyone on? Yes. Hi, Anush. Can you hear me? Not on YouTube though. Oh, did I not stream on YouTube? I think it should be on YouTube. I'm on there. Yeah, I'm looking at it live, Anna. I'm on YouTube, so everything should be streaming. If it's not streaming, Anna, you have my email. Everybody has my email. Advanced practice at archerpulse.com or hiva.kolodrubetz at archerpulse. You know I love hearing from my students. So give me a little rundown of how you felt the streaming was today and whether these webinars are available to you. Because that is my intention. I want to make sure you guys are getting these webinars. Okay, so when we're talking about hypertension, oh, my volume on YouTube is not working. Okay, I have no idea how to fix that, so I'm going to keep going, but that is really good to know. Working, okay. No, I have no idea. I'm going to hear some feedback if I do that. All right, I'll figure that out with tech on the back end. I appreciate it, Anna. All right, so with hypertension, what are we talking about? So you guys have probably heard American Heart Association, they updated these categories back in 2013. They also have really updated their guidelines on how we want to approach treating patients with hypertension with that prevent risk tool, right? So if you don't already know about prevent, you want to make sure that you have that calculator, you're using it as you're doing your clinical rotations. You're really getting familiar with these different categories. We're not going to go into the nitty gritty of the categories because you guys can read a chart as well as I can. But the point being is that we really want to keep patients' blood pressures low so that we're preventing what? Put it in the chat for me. What are we preventing? What are some of those conditions that we're preventing? I want to see from you guys. What are we preventing? Heart failure. Beautiful, Sandra. Love it. Right out the gate. Absolutely. What else are we preventing by treating the hypertension? Cardiomegaly, which is a type of heart failure. Very good, Sandra. Yeah. Stroke, Anna. Excellent. Yes. MI. Very good. Yes. So you guys are talking about a lot of cardiac remodeling, right? A lot of things that are due to the vasculature. Well, also, what about kidney disease? Right? What about eye disease, renal? Very good, Sandra. So all those end organs we really want to protect. So we really want to be a lot more strict. When they updated their guidelines in 2013, they made our categories a lot more strict. So back when I was training, stage 1 was 140 over 90. Now stage 1 is 130 over 80. Anything over that, we're considering that stage 1. And then in terms of treatment, AHA really has provided us a great tool with Prevent that now takes into consideration those younger patients too, right? Starting at age 30, to really be looking at their risk stratification for that 10-year risk of developing cardiovascular disease and having some of those adverse effects. So depending on that risk calculator, we can really think about, okay, if we have a patient in stage 1, what does that treatment look like? Can we stick with lifestyle, or is this patient at greater risk and we really need to start with pharmacologic intervention, right? And then same with stage 2 and so forth. One caveat that I will say is the difference between what you're going to do, what you're going to answer on the boards is different from what you're going to do in clinic. In clinic, I really want you to be thinking about, okay, these are the guidelines, but guidelines are just that. They're guardrails to really help show you what does the research show and where do I want to get with this patient. The reason why I say that is because guidelines say now that you can start a patient in stage 2 on 2-drug therapy with a single pill, right? Because their risk is so much higher. Now, in my clinical practice, when it's a board style question, that's how you're going to answer it. In my clinical practice, I really do not start patients on 2 medications at once because I don't know which one they're tolerating and which one they're having side effects to. So I always start with one medication, go low and go slow to make sure my patients are tolerating it. And secondly, those single pills are very expensive. So the guidelines have very good intention, right? They want to make sure we're bringing that blood pressure down. We're getting patients to take their medication. If you prescribe a single pill with 2 medications, they're going to be more compliant or more likely to be compliant with it. So I totally get it. The intention is great. but look at your patients on a case-by-case scenario. And does this patient have an insurance that's not going to cover that single medication, or is that single medication going to be super expensive, right? So you might have to be prescribing 2 drugs one at a time to make sure they're tolerating it, and then keep them on 2 drugs as opposed to a single pill, right? These are the things that I want us to really be thinking about and problem solving for our patients. It's really important. And again, not something necessarily that's taught in school, but I want you guys to be practicing that way when you're in the clinic setting. So we're going to be looking at prevent to see how we're going to treat those patients. And then we're going to be thinking about when we see hypertension in our patients. Is this really classic primary hypertension, or could this be skewing a little bit more towards secondary? And when we're thinking about those secondary causes, we really want to be pulling in those specialists to help us diagnose those secondary causes. That's really important. But primary is where primary care nurse practitioners really thrive, right? A lot of patients, it's based on their behavioral. So those lifestyle modifications we talk about. It could be environmental. And then oftentimes it can also be genetic. So I used to treat a really healthy patient population, very affluent, exercised a lot, took really great care of themselves. But genetics you cannot change, right? That is not a modifiable risk factor, and it can lead to primary hypertension. So really thinking about the underlying etiology helps us talk to our patients about a realistic treatment plan, and then we can really evaluate how well is that treatment plan working and how well is it not working. So you guys touched on this. So those target organ damage, right? So we really want to preserve those eyes. Think about all the vasculature in the eyes. So if we have increased pressure, what is hypertension? Hypertension is increased pressure in the vasculature, right? Always think about the pathophysiology. So the heart is pumping a lot harder to try to get the blood out, but that pressure, that increased pressure, is not only putting pressure on the heart itself and causing that remodeling. So a lot of things that you guys said with that cardiomegaly, that hypertrophy, right? That vascular disease, the valves start really failing us as well. So not only is it putting a lot of pressure on the heart, but it's putting a lot of pressure on the arteries in the body. And that pressure, those organs really get hit hard with that pressure, right? So in our eyes, all that vasculature, it can lead to retinopathy, right? In our brain, so Anna said it very good, in our brain, it can lead to stroke, right? It can lead to dementia, cognitive impairment. And then in our kidneys, it's one of the biggest causes of chronic kidney disease is uncontrolled hypertension, right? Think about all that pressure that is putting on our kidneys. And this is what we're trying to really prevent moving forward. So you guys hit the nail on the head. In clinic, you're not necessarily going to be doing these ocular exams. I have to be honest, maybe as a new clinician, I used to get in there and try to look in everyone's eyes, and patients were really thrown back by it. Think about how many times you go to primary care and your primary care providers looking in your eye like that. I would do your eye exam in clinical rotations. This is great. Yeah, get in there, practice that eye exam, fantastic. As part of your routine, you're not going to be doing eye exams. If somebody comes in with an acute complaint, I might go and do my eye exam and see if I notice any big warning signs, right? On the boards, you might see these as key terms to try to clue you into what's going on with the underlying vasculature for hypertension. So think about that for boards, and then think about how it realistically plays out in reality. Lab workup. So we talked about those end organs. So it's not just about the heart. We really want to be thinking about what's the etiology, what's causing this hypertension, and then how are we making sure that we are protecting those organs, right? CBC, why are we checking the CBC, you guys? Throw it in the chat for me. Why are we checking the CBC? It's hypertension, right? Why are we checking the CBC? Come on, Ria. Come on, Pia. Anna, Cachet, what do you guys think? Why are we checking the CBC? Is my audio on? I know I was talking at you guys. Why are we checking the CBC? Okay, good guess, Sandra. So the anemia platelet count, okay. So maybe if that patient has high hemoglobin hematocrit, then we could see some hypertension. So oftentimes that high hemoglobin hematocrit can be caused by a lot of different things that can lead to increased blood pressure. Maybe infection, okay. All right, so that's more acute, very good. So what I was trying to get at with the CBC is there are a lot of underlying conditions that can also cause hypertension, and you can see that in the CBC, including the hemoglobin and hematocrit. So you guys weren't totally off. So what is one condition where we see an elevated hemoglobin hematocrit? I know there are a lot of conditions, but related to hypertension, what is one condition that can lead to elevated hemoglobin and hematocrit? What do you guys think? And there's a clue on this slide. I'll tell you it's the last bullet point. But what can cause elevated hemoglobin and hematocrit? What do you guys think? That's right. Sleep apnea. Very good, Nusha. Very good. So sleep apnea can cause elevated hemoglobin hematocrit. So is this underlying sleep issue that's putting strain on the heart, right? What is sleep apnea? Where the patient is apneaing during the night, right? They're not getting enough oxygen. So the heart is working a lot harder to try to pump that blood out, and as a result, we see elevated hemoglobin hematocrit on that CBC. So could this be due to an underlying sleep disorder, right? Chem panel, what are we looking at in that metabolic panel? So a complete metabolic panel usually has blood sugar, sodium, potassium, those electrolytes, kidney function, liver function. What are we looking at? Very good, Sandra. Kidney function. Yeah, that's one of the things we want to be looking at. So kidney function, how is their underlying kidney function? Because if we're thinking about treating, or if we're thinking about secondary, or in general, how long have they had this hypertension? Is there some increased pressure? Do we see any decline in their renal function? Very good. We're also looking at their electrolytes. We're looking at the full chem panel, but really focusing in terms of hypertension on that kidney function. Same with UA. Oftentimes we can see some deterioration in that kidney function, right? If we see some proteinuria. And then why a hemoglobin A1C? Why are we thinking about that with hypertension? What do you guys think? What's the reason for that? Are we just trying to diagnose everything at once? Maybe this patient has pre-diabetes or diabetes, so we're just throwing the kitchen sink at them. What do you think? Why are we checking an A1C? Anusha, yeah, that's right. If they have diabetes, yeah. So even if they don't have diabetes, even if they have pre-diabetes, oftentimes patients with chronically elevated blood sugar levels will have hypertension, right? Those two go hand in hand. Why? Again, it's that pressure on the vasculature, right? A patient with diabetes or even pre-diabetes, elevated blood glucose levels, that blood is more viscous. So the heart's working a lot harder to pump it, the body's working a lot harder to circulate it, and it's just putting a lot of pressure on those arterial walls. So we really want to make sure, is there an underlying metabolic condition that's causing this hypertension? So we need to really tackle both. And once we get the blood sugar under control, maybe we can start coming off of some of those blood pressure medications as well. And then same with thyroid. So thyroid often is a little sneaky. Some people forget about it, but you want to make sure it's not due to an underlying thyroid dysfunction that's causing hypertension, right? And same with lipid. Lipid's the same idea with diabetes. So if you have high lipid levels, again, putting a lot of pressure on the heart, and you can get that underlying hypertension. So think about the whole body, right? When you're thinking about hypertension, what's going on in this patient's body? And let's order the labs that are actually going to give us a window. We're going to do something about those labs. So don't just order something just for the sake of ordering it. Know what you're going to do with those lab values. And then with the lipid panel, of course, with patients with hypertension, we want to decrease that CVD risk by making sure they don't have elevated lipid panel, and we're treating that if they do. So we're decreasing their CVD risk. Very good. So Ruth says, very static sound. I'm sorry, guys. I will try to work on that. I will get IT on I think really it's just all the different avenues we stream that we're getting all the static sound. I'll try to speak louder and closer to the computer. Metabolic syndrome, patients have hypertension often. Very good, Anna, that's right. Okay, and then the 12-lead EKG, this is something that I recommend. It's a way I was trained in clinical practice. But I always like getting a baseline 12-lead EKG, scanning it into my patient's chart, especially when we're newly diagnosing something like hypertension, anything that can really increase their CVD risk. Because then later down the line, 10, 15 years, as I'm caring for that patient, or maybe somebody else starts caring for that patient, it's in their record so that I have something to compare to as we see some changes in their cardiac function. So lifestyle, of course, always first line therapy. We always want to talk to our patients about how much physical activity are you getting. I'm seeing a lot of these studies coming out that say, even if you're getting physical activity before and after work, if you have a sedentary lifestyle during the day, that puts increased risk on your cardiovascular health. And so even I'm trying to move around every 30 minutes. I mean, it's a lot. That prolonged sitting puts a lot of strain on the body. There's some research coming out that it's saying it's the equivalent to smoking for our generation, and that worries me. We need to have these conversations with our patients. What kind of work do they do, right? And is it stressful? Stress can definitely wreak havoc on their metabolic system, right? Weight management, obesity, 100%, what they're eating, what they're drinking. So alcohol intake can absolutely cause hypertension, excessive alcohol intake, chronic alcohol intake. Smoking goes without saying. Smoking is like the number one risk factor for all types of cardiovascular disease. So we really want to be asking the question and talking about it at every visit. Even if the patient's not ready to stop, we want to make sure that when they are ready, they have a place that they can come to so we can assist them with smoking cessation, because it's not an easy habit to quit. So really talking to them about their lifestyle and following that prevent risk recommendations, whether they're low, medium, or high risk in that prevention score. So let's see. All right. So when we're talking about medications, and I see the time and I have some test questions for you guys, so I don't want to take too long on this. You have your different categories. When you're studying pharmacology, I want you to be thinking about what class does this medication fall into. So study the classes. Pharmacology on the boards, they're going to be asking safety questions. They want to make sure that you're a safe prescriber for entry level, meaning that you know what the mechanism of action is, you know those side effects, you know the contraindications. You don't have to worry so much about dosing. Anything that you can look up in clinic while you're practicing, they're not going to be asking nitty gritty of like how much lisinopril are you going to start the patient on. What they want you to know is that you know lisinopril is an ACE inhibitor, you know how ACE inhibitors work in the body, and that will really guide you to what those potential side effects are. So common side effects are going to be dry cough, of course, because of the way ACE inhibitors work in the body. So it's not something that's a contraindication, it's something that is expected. Patients who are bothered by it, you could try an ARB, but because of, again, the mechanism of action, they may have that dry cough with the ARB as well. So then if they can't tolerate it, it really bothers them, then we can try a different class of medication. But those contraindications, highly teratogenic in our female population who are pregnant and expecting. So this is a big no-no in our childbearing age, women of childbearing age, or planning, family planning. So asking those questions is really important because you don't want your patient on an ACE inhibitor who's planning on getting pregnant in the near term. You're going to start a different class of medication. Same with those ARBs. So when you're thinking about pharmacology, you want to be thinking about those high points, those safety points. When are you going to prescribe? When are you not going to prescribe? When are you going to go to a different class of medication? And really looking at those suffixes is going to be the best way to really practice those generic names in which class of medication they fall into. Beta blockers, no longer first line treatment. So you look at the guidelines, they used to use beta blockers as first line even before my time. And so now beta blockers, only patient population that it's first line in is really our pregnant moms. That's a big one. And then thiazide diuretics, any diuretic, really think about, again, the mechanism of action. So avoiding your patients with those renal issues, because it does put that pressure on those patients' kidneys, right? That's how it works. That's the mechanism of action. So when you're studying pharmacology, think about safety. JNC8 may still pop up on the boards. They haven't updated it. We use a lot more prevent now in terms of our guidelines in clinical practice, but this is also still relevant. Let's practice with a few minutes left. Nurse practitioner reviewing guidelines for renal protection in patients with diabetes. Which of the following medications will be added to the patient's plan of care? A, B, C, or D? What do you guys think? Put it in the chat for me. While you're doing that, I'm going to see if I can play around with the audio. Is that better for audio? All right, Sandra says C. Anna says C. Hopefully Ruth can hear me a little bit better. Maybe she got frustrated and hopped off. You don't see the question. Do not see the question. So it's on the screen. Okay, A, B, C, or D. We're having some tech issues, guys. I'm sorry about that. I don't know how much is on my end, how much is on everybody else. Okay, Jacinta says C. All right. And I see on YouTube people are saying, I can hear you, so that's good. All right. So C is the right answer. So what class of medication is losartan in? What class of medication is that? Tweety Bird says C. Absolutely, that's an ARB. So ACEs and ARBs to have that renal protection, right? And so we want to make sure, even if we have a diabetic who is not hypertensive, we're at least getting them on the lowest dose possible for that renal protection. Very good. This one's a little bit more meaty. 28-year-old patient presents for a new patient wellness visit required for employment. Patient reports feeling well, denies headache, chest pain, vision changes, dizziness, palpitation, shortness of breath. Ooh, that's a lot, right? There is no history of chronic medical conditions, and the patient does not take any daily medications. Family history, notable for hypertension diagnosed in a parent in the late 50s. They're giving you this patient's vital signs, so your medical assistant's taking those vitals, gives you a BMI. You go in and you repeat it manually, or maybe your medical assistant repeats it manually for you because you've trained them. Exam is unremarkable. Which is the most appropriate next step in assessing this patient? So I started to put these little meaty ones in here because the method that I use with my students is breaking down these really meaty clinical vignettes and answering the question in your own words before you look at the answer choices. So that's one of my methods. If you want to, I'm always happy to talk to you a little bit more about those methods, but my point is know what the question is asking, go line by line, pick out those key words that help you answer the question, and then answer it in your own words. That's pretty much the gist of it. And the reason for that is because every clinical vignette, they're going to give you those key words are going to guide you in answering that question. So don't overinterpret, don't underinterpret and read really fast. Really take your time when you're studying and break it down. Now, what do we think? What's the next appropriate action in this patient for assessing? So Sandra says fasting lab workup, blood pressure log at home, for a few weeks, follow up in a few weeks, lifestyle modification, diet, beautiful. I love it. So it's simply Benice. This is for nurse practitioners. Thank you for asking. And you're welcome to stay, but this is NP level style boards. So for those taking your NCLEX, don't panic. This is for nurse practitioner boards. All right, I love those answers. So let's look at our answer choices. A, B, C, or D. Is it A, initiate home blood pressure monitoring for at least 2 weeks? Is that in or out? I heard Sandra say that, so we'll keep that in. B, diagnose primary hypertension based on today's repeated office visits. Is that in or out? Can we diagnose this patient based on those readings? Is it C, begin an ACE inhibitor and reassess the blood pressure in 1 month, so follow up in 1 month? Or D, order lab testing to evaluate for secondary causes of hypertension? What do you guys think, A, B, C, or D? Looking at everyone's answers. Sandra says I would do A and D. I love that. So yeah, oftentimes it comes down to 2 answer choices, but this is not select all that apply, right? So you have to answer with 1. And Anusha says D, but what do you think? Jaquinta says A. Jaquinta now changed her answer to D. You're so welcome, Beneath. What do you guys think? Okay, Anna's saying A, Sandra's picking A. Yeah, it often comes down to 2, so that gets tricky too. So the right answer is A, and let's talk about that. I know it's 11:30, but for those of you who want to stay on, let's go through these. I have a couple of question bank questions for you guys. So A, we really want to make sure, first of all, this is our first time getting these blood pressure readings, right? This is a new patient wellness visit. Patient's feeling well, no significant personal history, family history, asymptomatic. However, blood pressure is above goal, right? And we're seeing their BMI is high too. So on the boards, they're going to give you what normal is, right? But you need to know what those blood pressure readings indicate. And you've done a manual blood pressure, or your medical assistant has. And my biggest pet peeve is making sure that you as a clinician know how to do a manual blood pressure, and your patients and your medical assistants do too. You don't need to make anybody feel bad for not knowing how to do it, but our role is to really make sure we're getting these accurate blood pressure readings, and we're training others on how to get accurate blood pressure readings, right? So in this scenario, I absolutely would check myself, do it manually myself after the patient's been sitting for 5 minutes, and then do the appropriate measurements, right? How you're going to measure accurately. And then I would train the patient on that and get some home blood pressure readings, because you want to see, is this truly elevation? Is this just a single today? Maybe this patient exercised 30 more shorter than 30 minutes before coming in. Maybe they've had a lot of caffeine this morning. We really want to make sure this is a true elevated blood pressure reading. So guidelines say you need at least 2 elevated readings across a 2-week span. And so that is best practice. Now, D, why is D not correct, you guys? You're so welcome, Sandra. Need to have 2. Yes, that's right, Anna. Very good, per the guidelines. So D is not the correct answer, because nowhere in this scenario is this patient really at risk for those secondary causes. So yes, you may order some blood work as part of your routine. You're meeting them for the first time. Maybe they have to have some blood work for their employment visit or physical, but we're not at this point really worried about secondary causes. So if that patient has hypertension that is resistant to medication, or if they have other risk factors like increased age, then we would be thinking maybe this could be secondary causes. Absolutely. And then B and C, we ruled out because we really cannot diagnose this patient and start them on medication based on 1 day's worth of readings. Very good. This one's a little bit more tricky, so I'm going to skip it and go to this last one to talk about pharmacologic management. And then we will do the more tricky one on our question bank when you guys log in there. So a 52-year-old patient presents for routine follow-up visit for management of primary hypertension. Patient was diagnosed 6 years ago and is currently taking lisinopril daily at a therapeutic dose. So you see how it's not really going to be testing you on that nitty-gritty of 5 milligrams, 10 milligrams, 20 milligrams, whatever. It's just saying, okay, patient's on lisinopril daily at a therapeutic dose. Patient reports excellent medication adherence, confirmed lifestyle modifications, including reduced sodium intake and regular walking. So they're doing those lifestyle modifications. Blood pressure readings over the past 3 months have consistently ranged from 148 to 152 for that systolic to 92 to 96 for that diastolic, including today's reading in the office. Okay, so thinking about those blood pressure categories, thinking about this patient's age, thinking about their comorbidities. What is our goal blood pressure? Put that in the chat for me. Patient denies dizziness, cough, swelling, other medications related to side effects. So they're doing well, no symptoms, suggestive of secondary or acute end organ damage. You also have some recent lab results that you can see their kidney function looks fantastic. And also their potassium electrolytes are within range. So what's the next best step in managing this patient? What do you guys think? Put it in the chat for me. What are we going to do for this patient? What do you think, Jaquinta? What do you think, Anna? All right. Love it. Anna says less than 140 over 90 is our goal. Do you guys agree? And then what are we going to do for this patient? If that's our goal, less than 140 over 90, is this patient at goal? And if not, what are we going to do? So Anna says add a second agent. Do you guys agree? All right. Add a second agent. Let's see what the answer choices are. So A, B, C, or D, continue with the current medication regimen, reevaluate blood pressure in 6 months. Why is that not appropriate? Why is that out? That's right, because we're not at goal, right? So we're doing nothing is also harmful to the patient, right? We don't want to overtreat and we don't want to undertreat. Both can cause harm to the patient. So A is out. Very good. And 1 month follow-up at least. Yeah, I agree with you, Anna. 6 months, that's not good. So B, add a thiazide diuretic to current antihypertensive regimen. In or out? What do we think? Anush says B. Anna says B. All right. C, switch lisinopril to beta blocker. What do you think, you guys? In or out? What do we think about C? Do we want to switch this patient's medication to a different class? No C. Tell me why, Anna. Why no C? And then D, order an ambulatory blood pressure monitoring before adjusting therapy. And why not D? So you're absolutely right. The correct answer is B. So we would add a thiazide diuretic to this patient's medication. We would add a second agent. I would not stop their lisinopril, right? Beta blockers are way down on the list. Absolutely, Anna. I would not stop this patient's lisinopril. I would add a second agent. That's what the guidelines say. And also, beta blockers are not well tolerated. They're not first line. There's no reason to stop this patient's lisinopril. They're at a therapeutic dose. They're tolerating it well. They just need a second agent to get that blood pressure within goal. Beautiful. And then ordering that ambulatory blood pressure monitoring. Is our office reading way off from the range at home, or is it in line with the range at home? Yeah, and Anush says beta blockers are not renal protected. Very good. Excellent. Yeah, lisinopril is an ACE inhibitor. Definitely want to keep that patient on an ACE inhibitor. Thiazide diuretic patients' renal function is good, so I don't worry about thiazide diuretic hurting their renal function. That's a great second agent to add. Very good. Yeah, and so blood pressure reading in the office is in alignment with the readings at home. I don't need to have this patient prove that they do have a higher level or above goal blood pressure before adjusting therapy. We're going to address the therapy. And then the side effects for beta blockers, the sexual side effects, absolutely, Anna. Yeah, patients do not like beta blockers. So basically, we really want to be thinking about what is this underlying condition. It is silent, so not only as clinicians getting on board with treating hypertension, but getting our patients on board with treating their hypertension and really talking about realistic care plans on what they are able to do, and the guidelines are really just our guardrail. And then when we need to, pulling in our specialty partners from the community when it's something that is refractory to medication, or we feel that maybe this is due to a secondary cause. That's really important. So do not be afraid to refer patients out to cardiology, especially patients that have really complicated family history or risk factors. Maybe they have a really prominent family history of cardiovascular disease. They're young, they're doing great. I oftentimes like cardiology to weigh in on prevention so that we can make sure that we're doing what we can to really get this patient to stay healthy for as long as possible when we're working against their genetics. But those cardiac conditions that are really complicated, we definitely want to make sure we're co-managing these patients. So in our pediatric patients and our pregnant patients, absolutely 100%. So those questions came from our question bank. We have over 1,600 board style questions. You can filter on which boards you're taking. Usually I ask people which boards they're taking, but as you can tell, I get a little chatty and I'm trying to stay within that 30-minute window, and I still went over today, so my apologies. But you guys can, whoever wants to stay on can put it in the chat for me. I always love to hear from my students. Where are you in your training? Are you family nurse practitioner student? Are you a different specialty? Are you getting ready to sit for your boards? Which boards have you decided yet? I really love to hear from my students, so you can throw that in the chat for me. And then also use our question bank as you're studying. It's really important because evidence does really show that you don't need to master the material before you start practice questions. Practice questions can actually help you identify those knowledge gaps and be able to focus those areas that you need to go back and actively study, as opposed to just like mindlessly read where you're not really retaining any useful information. So use those clinical vignettes to really understand, okay, if I see this patient in real life, what am I realistically going to do in an outpatient setting? And then you have the tools when you do see that patient in an outpatient setting. I promise you, if you practice that way, if you learn that way, you will have that intuition going into practice. We also have a video library. I think it's over 16 hours now. That's probably an old quote, because we've added a lot to that video library. We've added the head to toe exam. We've got a lot of advanced assessment exams, so like speculum exams, otoscope, all of that. It's really nice. It's thorough. So make sure if you are looking for a question bank, you do the combo at least so that you have access to those videos, because the videos are linked into our question bank as well. So it's helpful to have both. If you just want to have everything, there's the SurePass that bundles in the question bank, video library, also our board prep, we're calling it the power prep because it's a 1-day live review, but you can also individually purchase all of those things too. Okay, so now I want to show you guys what it looks like from the dashboard side. So this is my student dashboard. Don't look at this, I use this as an example, but definitely want to make sure your dashboard is improving when we're looking at remediation. But if you purchase the SurePass, which gives you access to everything, you'll have that question bank, the video library, as well as the SurePass live review. We're doing live reviews now once a month. So when you go on to the live webinars, you should be able to see those power preps coming up. And then you should also be able to see those free webinars that we have on the calendar too. So next month, I'm diving into hyperlipidemia and CAD, similar to what we did with hypertension today. So going over the meat of it and then doing some practice questions. I am going to keep working on trying to pare it down to 30 minutes, I promise. Morgan Boosie does a lot of beautiful lectures for us as well. She's my partner with those power preps, and she also does free webinars. So if you look in that live webinar space, you'll be able to see it. When you're in our question bank, you can create those tests, and when you pull it up, you can really filter it. You can start with the readiness assessment, which really tells you where you are and where we need to go with your plan, of your study plan. Or you could go right into just practicing questions. I recommend putting it in that tutorial mode, timed mode, and then it really gives you the option of the board style exam if you want to select all that apply, or if you just want those single best response. You pick unused, and then you pick your test questions. So I always tell people start with 25, filter it with the population. So say today you wanted to study geriatrics, and then you're going to focus it in on neurology, and then it'll create that test for you. So it's a really nice way to study while you're mastering the material. It reveals the answer, tells you which one is right, gives you the explanation, links it to a video. Really useful for you to mark those off and study in that way. All right, you guys, and you can get all that when we have a demo, but when you go to our website, you can log in, and that's called a dashboard. So that's what I just showed you guys today. All right, well, thank you so much for joining me today. Anusha shared studying for FNP-ANCC. Very nice, good luck. If you guys have any questions, don't hesitate to reach out with an email. We also do mentoring and tutoring, so please reach out to either myself or Morgan if you can't find a time slot that works for you. We do a lot of accommodations. We just throw a couple of slots out there that work for our schedule, but we definitely accommodate because we know you guys are working and school and all of that. So if there's a time slot that you need that you can't find, reach out to us. And thank you so much for joining today. And it's great to see all of you. So thank you again, and enjoy the rest of your Wednesday. Bye, you guys.